Okay, so I'm here. You can start a practice session if you want. Let's start that now.
Good morning, everyone. My name is MK Graham. Happy Thursday to each of you. And on behalf of FADA, welcome to today's webinar entitled Compassion Fatigue in Families Affected by Substance Use and Trauma. This webinar is being made available through a collaboration of the Florida Department of Children and Families and FADA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them to all panelists by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. Our presenter will address the questions as time permits. Our audio is broadcast through the internet on your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try to use by using the Communicate menu. For computer audio, click Communicate menu, then click the Audio Connection panel. Click Disconnect. Click Communicate menu and Audio Connection again. Then click Call in using computer and follow the instructions. If you continue to experience poor audio through your computer, try using the I will call in option under the Communicate menu. The access code and event password are posted in the chat panel. You may be connected to the audio of this presentation and also view it on screen to receive statement of completion. If you are unable, we are unable to verify attendance if you are not connected to WebEx via your computer or mobile device. Therefore, audio-only attendees will not be eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, visit www.fada.org. Navigate to the Resource Center and click on the Training Library as shown on the screen. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through FADA. A statement of credit and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, mental health counseling, and for persons credentialed through the Florida Certification Board. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at the end of the day on Wednesday, May 29, 2024. At the end of today's webinar, you will have 3 options to complete the evaluation. We will post a link in the chat. A follow-up email will be sent from WebEx, and an automatic web browser pop-up will pop up after the end of this webinar. To complete the evaluation, you will first need to register or sign in to your account. Please ensure that your name and email address match the name and email you used to register with WebEx. Information you provide FADA as part of registering remains confidential. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register on our site. If you need assistance with account registration, login information, or accessing the evaluation, please fill out a contact form on our website or email training@floridabha.org before May 29th. Please note that WebEx monitors arrival and departure of attendees and provides a report upon completion of this event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar. And we are not permitted to provide partial CE credit. Statements of credit will be posted within 30 business days after the evaluation closes in the professional development section of your FATA account. For licensed practitioners, CEUs will be reported to the CE broker within the same timeframe. Please note that this presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published on various media. Now, I have the pleasure of introducing our presenter today. Dr. Michael Barnes is a licensed addiction counselor and licensed professional counselor in Colorado and is the director of the Michael Barnes Family Institute. Dr. Barnes, I'm now going to turn it over to you.
Thank you so much. Good morning, everyone. It is such a pleasure to be back in Florida. I moved to Denver in 2010 to take a faculty position at the University of Colorado in Denver, and I just got back. I moved back 2 weeks ago, so it's really interesting. It's like riding a bike, learning how to deal with the heat and the humidity. So it's been wonderful. So this is a project of mine that I have been focusing on for the past 30 years, and so many programs around the country are either downsizing their family programs, and many programs are actually closing their family programs. And I have been adamant about the fact that we need to, if we really look at family research and we look at the research on families and addiction, particularly if we look at the medical family therapy research on chronic disease management, that clients are far more successful in managing their chronic illness when their families take an ownership role and a recognition that they've all been impacted, that recovery becomes part of day-to-day life, that everyone works on their own issues. And so I have been speaking on this topic for, the last 15 years. So what we're going to do today is we're going to talk about 3 primary objectives: identify the signs and symptoms of burnout in members of families affected by loved one substance abuse, identify the signs and the symptoms of secondary and systemic trauma, and then how to implement certain interventions. And we're going to do it in 3 sections. So the first section is really going to be explaining compassion fatigue. Hopefully everyone on this call is familiar with the concept of compassion fatigue when it comes to working as a professional in the field. I'll talk a little bit about how the concept of compassion fatigue was not started at Florida State University. It was started at UCLA, but how Dr. Charles Figley played a key role in helping the counseling profession understand the impact of working with clients on the mental health and well-being of us as professionals. And so we're going to talk about that, burnout and secondary trauma. We're going to talk about chronic disease management. I'm going to introduce you to a model that was developed by a gentleman by the name of Dr. John Rowland, and it's a model that's called the Family Systems Illness Model. And when I was developing the Foundry Family Program, it's interesting, during COVID, I was doing what everyone else was doing, cleaning out my garage and trying to find things to do to keep busy. And I found this box of papers that I had written I didn't realize what was in it. It hadn't been opened in years, but it was all the papers that I had written when I was a doctoral student in the marriage and family therapy program at Florida State. And the very top paper was a paper that I had written in December of 1991. And the title, and this tells you how long ago it was written, it was Residential Alcoholism Treatment. Is it time for a family systems paradigm shift? And when I read the paper 30 years after I had submitted it, it dawned on me that we're actually no further along in our integration of family work and addiction treatment, or not even in our understanding of the co-relationship of family health with the folks that we're treating's successful recovery. And so I developed a program out at a treatment center called the Foundry in Steamboat Springs, Colorado. And that's really what evolved into the Michael Barnes Family Institute. And then the last thing we'll talk about are clinical interventions. So compassion fatigue. So I was at Florida State. My mentor was Dr. Figley, and he came into the student office and he had a letter, and it was a letter from a woman by the name of Carla Joinson. And Carla was affiliated with UCLA School of Nursing. And the letter basically said, I've been following the work that Dr. Figley has been doing on secondary trauma. And we view it as what we call compassion fatigue. And we see it as more about burnout. And you all in your clinic seem to see it as about trauma. And as we kind of talked about it, we began to look at the compassion fatigue is the interrelationship between caring about someone and the burnout that comes from changes in our organizational lives. We'll talk about that. And the secondary trauma is part of what we would call our operational lives, the actual day-to-day interaction with the individuals that we treat, but that families deal with. And Dr. Figley wrote that the field of traumatology has inadvertently ignored a large segment of people, the family and other supporters of survivors. This suggests that there's a kind of transmission of trauma from the survivor to the supporters. This phenomenon is described as compassion stress. And the most negative consequence of this stress result is compassion fatigue. So at the very beginning of our look at our investigation of compassion fatigue, families were included. We really viewed it as that's exactly what the families are going through and my interest was in addiction. I have a 37-year-old son who was hit by a car when I was, it's interesting, the paper that I just talked about, I had submitted to this class 40 days before our son was hit by a car, spent 3 weeks in intensive care, 3 weeks in the hospital, months in a body cast. And the idea of secondary trauma or the trauma of the family system became very real to me and became really an area of study. So compassion fatigue isn't just for professionals. It is very much experienced by the families that we work with on a regular basis. Many people will say to me, don't you think it should be called empathy fatigue? And I've thought about that a lot. And I went back to some of the writings by Carla Joinson, figuring if she's the one that identified the term, I'm going to side with whatever she says. And I mean, where empathy is that sort of co-occurrence of emotions and similar thoughts and understandings of an experience that another person is having, compassion is actually the deep awareness of the suffering of others. And Carla made the comment in an article that she wrote that said, it's called compassion fatigue because it is about the day-to-day interaction with people who are in kind of extreme states of suffering. And that we're not just empathizing with them, but we're dealing with their symptoms. We're dealing with their struggles. We're dealing with their emotional consequences, their emotional response to us. And that is that recursive process. And so it was her opinion that compassion is really what leads to burnout and to secondary trauma. So I'd like to start any discussion of compassion fatigue with, this is from Carla Joinson, from the very first publication that she ever made or did, associated with compassion fatigue. And she says there are 4 reasons that we should be aware of it. Now, she's talking about being aware of it as practitioners. She worked with critical care nurses and emergency room nurses. And I look at it as a family therapist and as a family educator, that the families that are coming to me are experiencing all 4 of these issues. The first one is that it's emotionally devastating. And we all know that if you work with families, that there's always great sadness and grief. And we'll talk about grief in the secondary trauma section as well. There's depression, there's exhaustion. That is just part of the experience of living with an individual. And I was writing a blog yesterday, and I said at a point where the individual's disease of addiction is progressing to a significant point that is, they become unpredictable, or unfortunately, they become so predictable but unstoppable. And so that idea of emotional devastation is, what do you do in a situation that is that unpredictable or that sadly predictable? Number 2, caregivers' personality leads them to it. And we can imagine as therapists, our personality is wanting to help, wanting to be present for people, wanting to be good support systems, and multiply that by 100 as being a parent of a kid with addiction, or a partner of someone who had, hopes and dreams for a marriage or a relationship that would be lasting and would be, the kind of dream relationship, that we begin to realize that Dr. Figley used to write on a fairly consistent basis that compassion fatigue is the cost of caring in relationships. And the third one, the outside sources that cause it are unavoidable. When we think about, I'm going to show you a slide of some research that I did with families and asking them what are the most traumatizing aspects of having a loved one with addiction. And we'll see, we're talking about emergency room visits, arrests, deaths, overdose, all these kinds of things that are incredibly traumatic, not just to the client, but to their family. And the last one, I think, is the most important. And I think it's really important whether you're a practitioner and you're looking around at your coworkers, or if you're looking at the families who come to receive services, but that the person who has it is the last person to know they have it. And the idea that the mission is so critical to them that they generally tend to minimize the impact of it. And in our family program, I have multiple videos that I give to the family members. And when the families watch the video on trauma, and it's about PTSD, but it's also about the neuroscience of trauma, invariably family members will come in to the next group and say, I had no idea how traumatized I was. I had no idea how this has impacted me, which really leads them into the next video, which is on secondary or systemic trauma. So the idea of working with these families, education is as important as anything. And we're going to talk about the role of coaches versus the role of therapists. And in a perfect world, I think having both working with the same family in conjunction in an organized and methodical way is the absolute best way to do it. So that when we look at what compassion fatigue actually is, it is a recursive process where there's experience of burnout or organizational stress and secondary trauma. And there are generally, in my mind, and having worked in this since 1995, when Figley's book was published, and when we all, doc students help out faculty by editing and talking to the authors of various chapters and all of that. So I've been really doing this since 95. That increased family stress, burnout, or exhaustion, that issue of organizational stress, increases the use of what I consider to be ego energy, or the energy that allows me to be able to make this distinction between where I end and my client that I care very much about, or my loved one that I care very much about, begins. And so that the more stress we have, the more burnout we have, the more exhaustion we have as parents, as partners, as siblings, as children of individuals with addiction and the significant co-occurring trauma, that it opens the door to an increased experience of secondary trauma, or that day-to-day interactions with that person. The opposite can happen as well. And I think it's as common, maybe not as common, but I think maybe in the kind of later phases of the development of compassion fatigue, as the addiction becomes more and more advanced, that things begin to happen that are so traumatizing to that individual that it uses up all of the energy that they have just to be able to cope. And if we think about how trauma memories work, and how it's sensory based, and there are going to be reminders all around the house that we're going to be paying attention to facial expressions, thinking polyvagal theory, and being aware of nonverbal communication, that there are just so many things in the interaction in the day-to-day world between family members and someone with an emerging, growing addiction that are going to trigger those secondary trauma issues, which then create increased burnout of having to try to keep all the balls in the air for that family. So when you think about organizational stressors, Tom Cornell and Dan Barato, who were also at Florida State, and I had the great fortune of doing some research with them, really talks about family organization as being the rules, the roles, the routines, rituals, relationships, and boundaries. And we'll talk a little bit about how they shift. And everyone who works with families knows how, the don't talk, don't feel, don't trust rules in the family begin to shift. And I'll talk a little bit about that slow, progressive, unconscious shifts that are happening in that family as they move from the normal to the new normal of living with this addiction. And so often families will say to me, well, if he would just get sober, we could go back to normal. And the reality is that the normal ship sailed a long time ago, and that this family has been developing new rules about communicating, new rules about what's allowed to be emotionally stated, autonomy, those kinds of things, that they've created a new normal that is intended to help them be able to live with and adjust to and deal with progressing addiction, while also keeping all the balls in the air for the rest of family functioning. Operational stressors for secondary trauma are just our day-to-day interactions with our family members. And I ask families, one of the stories I talk about, I wrote a book called When the Solution Becomes the Problem, helping families who coping, dealing with addiction and trauma. And a lot of what I'm going to talk about today is how the solution in dealing with this burnout and with this secondary trauma creates a new normal for this family to be able to survive. But over the course of time, this new normal becomes the solution that is the problem that actually brings them into treatment at some point. And so one of the things that I ask families a lot is, how long does it take for you to recognize when your loved one walks in the front door of the house that they're impaired or that they're intoxicated? And while families give all kinds of answers to that question, the most common is 2 seconds. And then we talk a little bit about the hypervigilance of that. And they talk about, well, if he's sober, our life in the house is going to be different than if he's intoxicated. And then we'll have to initiate all kinds of ways to keep everybody safe. And so then I ask the family members, so let's just imagine that your loved one's been sober for 1.5 to 2 years. You haven't seen them for a while. You're assuming that they're busy with work and with hopefully going to meetings and other recovery kinds of activities. And the door opens and they're walking down the hall to greet you. How long before you think to check out to make sure that they're still sober. You would think that in a 1.5 to 2 years of sobriety and recovery, that family would have begun to work through those trauma responses. And I think that's a trauma response. We'll talk about that. And the average answer to that question is 2 seconds, the same as when they're in the middle of their addiction. And that is, I think, symptomatic of that sort of new normal that the families kind of develop in order to cope. And I think that new normal is a response to secondary and systemic trauma. And that's actually what this slide is about. That idea of normal was back here before the addiction started. That if you ask families, and I ask families, this is one of the tools I use. Typically, I have a mobile over here, like a mobile over a baby's crib that kind of adjusts to influence and impact. And ask them to begin to look at these symptoms that are kind of part of a progressing severity in a loved one's addiction. And to begin to, like when they'll say, well, okay, I remember, when he started to get aggressive with us, he started really pushing back on our attempts to sort of, manage his behavior. And then I will ask them, so how did you adjust to that when everything that you've tried, the old saying is, what's the right thing to do when you think you've tried everything? Is that how do you help them begin to realize that we have been making subtle shifts to adapt to these changes while also trying to keep everything going, that this new normal is the really what we need to be treating. And we need to be really clear with the family on what that is, how that works, why that was an incredibly functional thing to do to create that level of operation or organizational stress. So and families really respond to this, and that's one of the things to get them to begin to really look at. Yeah, I remember when this happened, and we really did struggle to try to figure out how do we deal with it. Okay, so just a question that I would ask you to kind of respond in the chat. Have you ever experienced compassion fatigue yourself? And if so, describe a little bit about what you experienced. I would also ask if you're resonating, if you're a family professional and you're resonating with this, what are some of the things maybe that you have seen in the families you've worked with that would be consistent with compassion fatigue, like both burnout and secondary trauma? Feeling powerless, yeah, that's a huge part of it. Do I have family members define their new normal? Yeah, I think that's really a pretty powerful thing to have them begin to say, well, this is what we tried. This is what we figured we had to do in order to keep everything going. So it's really a collaborative. And remember, 4 people on 4 corners watching the same car accident will tell you 4 dramatically different stories of what happened. And so one of the things that I have learned in working with families with very severe traumas is how different everyone in the family story is about what happened, who was where, who said what, all of those things. And by having them kind of redefine the new normal, the story of what new normal is, it's really a nice way to begin to get them to be able to hear one another and begin to listen to one another and to begin to recognize, I never knew you thought of it that way. I never knew that's how you understood it. So it is one of those things that I think is really helpful. Okay, and thank you for all of your comments. That's fabulous. Thank you. Okay, so understanding burnout. So three definitions I like. The first one is so we tend to think of burnout as something that has to do with work, and it doesn't. It has to do with being a state of physical, emotional, and mental exhaustion caused by long-term involvement in emotionally demanding situations. What is a more emotionally demanding situation than watching someone you love spiral out of control and begin to have consequences that are so unstoppable and unpredictable? Dr. Figley writes, family burnout is the breakdown of the family members' collective commitment to each other and a refusal to work together in harmony as a function of some crisis or traumatic event, series of crises or events that leave members emotionally exhausted and disillusioned. I hadn't planned to talk about this, but that reminds me of a story of I was teaching and a student asked me, what's the best way to work with an unmotivated client? I thought about it for a second and I said, I don't know. I've never worked with an unmotivated client. I'd love to hear how you all would have answered this question with a student, but I thought the student was really setting up this artificial dichotomy of that people are either motivated or they're not. And I said, I work with pretty severely traumatized clients, and that they're all motivated for something. Some are motivated to stay the same because that's, as painful as it is, it's still safer than trusting people. It's still safer than taking these enormous risks to begin to make these changes. And so I said that traumatized families and traumatized clients are highly motivated to stay as safe as possible. And I think it's really important to understand that Figley's comment about burnout and the breakdown of families' ability and willingness to work together is the result of a new normal within the family where the rules have shifted to such a degree that it's not okay to be you anymore. It's not okay to say what you think anymore. It's not okay for you to express your feelings anymore. And that we'll talk about that the longer family members stay in fight or flight, that they begin to shift away from the normal important things in life to how do we deal with all of this vulnerability? And one of the things that seems to happen is that they begin to recognize that the person that's struggling with the addiction, that their needs have to supersede the needs of everyone else. And so that begins to minimize the needs of siblings and of other partners and things like that. The last one is written by a guy by the name of Kotler, and he wrote a book, I can't remember what it's called at this point, for counselors. And he said, burnout implies like a huge flaming experience, that it's really better identified as rust out. And rust is this really slow, gradual process that eats away at a caregiver's spirit. And we talk to families that at times are experiencing this powerlessness, and in many cases have a sense of hopelessness, and that's a great sign of that burnout or that rust out that is experienced. So what are the things that happen in families that cause burnout? Number one is the initial shock of it. And, you know, we work with families that the loved one is a 35-year-old who lives in Denver, but the family has lived in, Hollidaysburg, Pennsylvania, my hometown, and haven't been there to see or experience the consequences as they've begun to grow. And so for them, getting that phone call that says, Joe's in the hospital with severe medical complications because of his addiction, they don't even know they're not even necessarily aware of the severity of that. So for many families, that initial shock is a trauma, is a significant an event that overwhelms our coping strategies, overwhelms our defense system. And so they will often talk about, even though it was a pretty horrible trauma to get that news, I can't imagine what living with the progressive nature of that was for their partner or for their kids and things like that. The second, the progression of the illness is really, in my mind, what causes burnout in families. the emotional decline, the negative behaviors, the increased mental disturbance or the mental mismanagement, the physical deterioration, the esophageal varices, cirrhosis of the liver, hepatitis, and other complications. And then the burden that as the individual in the family, particularly if it's a parent or a partner, the burden of shifting roles, the parentified children, the partner who is now both the primary caregiver but also primary breadwinner, that burden begins to have an accumulative effect that creates burnout. Other things that cause it are changes in family organization, chaos, and secondary and systemic trauma. So the term I use to describe organization are the 5 R's: rules, roles, routines, rituals, and relationships or boundaries. And anyone who's worked with families for any period of time really understands how those begin to shift as the illness progresses. We tend not to, we may even use the term organization, but we have to understand, how does organization happen? And organization happens by 2 people coming together out of their own families of origin, having their own kind of what is normal in terms of being able to speak honestly, to experience your feelings, to take risks, and to be autonomous, joining with another person who may have grown up in a family with severe addiction where none of that was normal. And so they have to negotiate that. And there's the famous story by David Foster Wallace that he gave at a commencement exercise for college somewhere. I can't remember what college it was, but he talked about the fish in the water, and the idea that 2 fish are swimming down the stream, and another older fish comes by and says, "Hey fellas, how's the water?" And the 2 little young fish look at each other and like, what's he talking about? And then as they swim away, one looks at the other and says, "What's water?" And water is the world that we live in. And my family's water, with its addiction issues and its trauma issues, is really different than other families' water. So that idea of what is normal to them is this accumulation and integration of multiple family historical issues. So if there's historical trauma, if there's racial trauma, if there is transgenerational trauma associated with illness and injury, that original normal that everyone kind of assumes is pre-addiction may actually be setting the family up for interacting in ways that actually support the addiction rather than stop it. As a family therapist, I'm always looking at, what are the interactional factors that are actually maintaining the problem? And then how might we change those to begin to change the problem? Living in a constant state of fight, flight, freeze, disillusionment that comes with that, the exhaustion that comes with that. Family members overshadowed by the substance use, the idea that, my sibling gets away with murder because of his addiction, and I'm an A student, and every time I do anything, I get into trouble. Or, just there's so many examples of the idea of where we're tiptoeing around on eggshells with one family member, and coming down with the hammer on others. And I was working with a family where there were some siblings, and these siblings were in their late teens, high school years. And one of the siblings said to the parents, "You haven't been to one event, my track meets, my, band stuff at school." And that, like, all you think about is my sibling. And I get it. But that idea of I am invisible compared to my other siblings has an impact on self-development, on life cycle stage completion, on everything. Conflict and tension, and the progressive development of build-up stressors, financial issues, legal issues, medical issues. So all of these things, when you start putting them together into the water that this family is swimming in, kind of changes the pH a little bit and creates a significant amount of exhaustion and burnout. So a researcher by the name of Maslach, a very famous burnout author, says that there are 3 dimensions to burnout that are critical, and that as a therapist working with families, all of these have to be addressed on some way. And I'm going to guarantee that you've all worked with people, and you may have even experienced some of these yourself during periods of burnout in the work environment that you've seen. And the first one is disillusionment. The idea that, you know, I was so looking forward to being a parent, or I was so looking forward to be a partner in this life journey that we were starting. And man, every time there's a problem, I get blamed that it's my fault for the problem, or I should have done something different, or this other person never takes responsibility. And that the burnout comes from the disillusionment and a growing sense of ineffectiveness and a lack of accomplishment, and that I should be better at this, you know? And so in the employment world, the research would tell us that if someone is talking to you about help rejecting complainer, absolutely. Talks about if your employee is already talking about you know, their dissatisfaction in their job or wanting more money or one of those things, that the reality is that they're already looking for a job. And so it's kind of the same thing within families, that you know, families, when they begin to experience this, they don't have the awareness to say, you know, that's not right. I'm trying my best. I'm doing my best. And so what they do is they try harder. And so we've all run into that person who we've tried to use the analogy of the airplane, where we said, you know, the flight attendant says, put the mask on yourself before you put it on your kid. And they look at you aghast to say, no, I can't take care of my needs until I'm sure that my loved one's going to be okay. And I think that that's what happens with that beginning processes of burnout is I need to work harder. I need to do more. I need to get more help. I need to ask more people. The second is exhaustion. You know, doing more with less, particularly in situations where there are these incredible role changes that people are doing multiple people's jobs within keeping the family together. And the third one is the one I find most interesting, and that's cynicism, and resulting from unrealistic expectations, a lack of resources. We've been trying for a long time, and so people get angry. And we've all worked with family members of loved ones who came to our family programs or came to our therapy who were just angry. They were angry at their circumstances, but they didn't own that anger. They you know, were a bit passive aggressive, or they did a lot of gotchas. And one of the things that we'll talk about in the secondary trauma aspect is that throughout all of this, when families cannot find the way to self-soothe, then they begin to put it on you as the provider of it. It's your job to make me feel better. You need to tell me what I'm asking for, even if it violates. I did a research project once where everyone was really angry at the treatment providers because they wouldn't break confidentiality to give them information about how their loved one was doing when there weren't releases signed. And so they don't particularly care about the law. They care about feeling better. They feel about getting some answers. And I always called cynicism thinly disguised contempt. And that idea of I'm angry, but I'm not going to talk about it. I'm not going to address it, but it comes off as that sarcastic joke, gallows humor, those kinds of things. And so, I would love to see in the chat if any of you have ever either experienced any of this. You know, I think I skipped over the exhaustion part, but I think we've already talked about that. Or if anyone has ever worked with a family where there were family members that clearly met these criteria, and the idea of think how many, I don't know about you, but I get asked a lot, So what do you think we should do? And there was a time when I would just tell them, and 99% of the time they didn't do it. And so now when someone asks me, what do you think I should do? I always say, well, let me start with a question. Like, if I tell you what I think you should do, will you do it? And the vast majority, people never say no. And occasionally they'll say yes. But the vast majority of answers is, well, it depends on what you tell me. And that is that person that has been, and there's a million reasons for asking, what do you think we should do? And I love that answer when they say it depends on what you tell me, because it opens the door to a whole new discussion about what have you tried? And, you know, I can't tell you what to do if I don't know the history and I don't know the context and I don't know these things. Are you willing to share with me what's going on with you rather than what's going on with your loved one? Why did you try what you tried? And a lot of times that's an introduction to the idea for family members that it's really about you and your change more than it's about your loved one. Now, in the treatment environment, your loved one's getting the treatment that they need to do those, but for us, that's what we're kind of dealing with. So I'm always looking at these when I'm working with families. Not only am I looking at them, I'm expecting them. And so that's the other thing is I tell my staff all the time, tell me again why we're upset with a traumatized client who's acting like a traumatized client. Like, we should be expecting these behaviors, right? And so, and with families, and when they're defensive and when they're pushing back and they're hypervigilant and they're controlling and they're traumatized from all of this, why would we expect them to not do that? So our programming has to be specific enough and flexible enough to begin to address those issues and help them begin to see it. So symptoms of families experiencing burnout: feeling burdened, worrying, hypervigilant, controlling, exhausted. Almost every family I've ever talked to has told me that they have sleep disturbances, they have a hard time falling asleep, they have a hard time staying asleep, they dream about their clients, changes in weight, irritability, anger, loss of interest in activities. That's the other thing that's really interesting. The research would tell us that the things that we do for self-care take energy. And if our families are exhausted and the needs of the client and their family, the identified patient, I'll call them, takes precedent, that the things that they would typically do to give them relief are the last things that they do because they don't have the energy to do that. And from a business or from a professional compassion fatigue perspective, I can't tell you how many people I've worked with who have said, you know, I used to run, I used to ride my bike, I used to go to the gym, I used to dance, and you know, I'll ask, what do you do now? And it's like, watch TV. I'm exhausted. I sleep, and so those kinds of things. Many misuse their own substances in the process of trying to cope, and the idea of neglecting self-care. So these are symptoms of burnout that are specific to virtually anyone who has burnout. This isn't just for our clients. So you kind of answered this in the chat already, and I'm so grateful that you're participating. What has your experience been with burnout of family members or natural supports? And you already talked about that, but if there's any other ideas that you have, that would be awesome. Just go ahead and put those in. And I'm gonna get a copy of this chat. And there's just so much rich material in there that I really want to be able to kind of understand it better. Okay. So I'm going to spend a little more time on secondary trauma because I think it's more complicated. I think, and so I'm going to talk to you about the outcome of my research. And so from my research, I've identified these sort of siloed sort of areas that families experience and demonstrate. And so this may just seem like I'm throwing random stuff at you. It is not random at all. This is all part of research that I've done. So this is just material from, these are some quotes. So CEDAR is the Center for Dependency, Addiction, and Rehabilitation at the University of Colorado Hospital System. We had a large treatment center. I was the clinical director for that treatment center. And I did some research with the families. And one of the questions I asked was, is living with a family member who is struggling with active substance use disorder traumatizing? And there were 260 participants at the time. 74% of the family members strongly agreed that it was traumatizing. 21% agreed that it was traumatizing. That's 95% of all of the family members, when asked, were able to recognize that, wow, this is more significant than I thought. So, you know, when I first started, I remember doing my first presentation on trauma integrated addiction treatment out in Colorado. It was like 2013, and people were looking at me like I had two heads. It was just so different, and now everyone talks about it. And I think we need to do the same thing with families. They act the way they do in our family programs because of what I'm talking about right now. So, quote from a mother. This was a mom of a 20-year-old daughter who had a significant addiction to heroin. And the mom was part of a research project that I was doing. And she said, it's been really been overwhelming. I can sit here calmly and talk now, but that's not the same as when I don't know where my daughter is and what's happening. And I'm getting phone calls from somebody on the street saying that she's been beaten, she's been raped. I mean, you know, really bad things are happening to her. It's not such a calm feeling when you get those phone calls or get phone calls in the middle of the night. I think there must be some sort of post-traumatic stress disorder for families going through this. And this was a research project that I did in the early 2000s. And so the idea of secondary trauma had not really become very popular at that point. So I was pretty impressed with her ability to put the pieces together. And the last one is a mom of a 37-year-old with chronic co-occurring disorder. And this is just to show you the mentality, kind of where family members are coming from. And she said, my second son has mental health issues and is an addict. It's been difficult for our family unit to understand where he is coming from, how this happened, etc. I often wonder if there will ever be a light at the end of the dark tunnel. He's now 37 years old, about 25 years into his dual illness. However, I see myself in this segment of the webinar instead. I've never been diagnosed with post-traumatic stress disorder, but what I read and follow along in your presentation, it was like I was being spoken to. When I started the family program at Foundry, and I was talking to colleagues about it and talking about the extent of it, the groups and the videos, and I was told by so many colleagues, families don't want that. They'll never attend. And that is not accurate. 70% of our clients' families attended and participated. And so families do want it. They initially might recoil from it, but how it's done and the progression of educating and supporting and coaching, eventually they get the picture of, wow, you really are talking about me. So in that same study of that mom that I just talked about, I had asked, they were talking about trauma. And so in a second iteration of questions for the participants, I asked them to identify the sources of trauma for them as parents of individuals with addiction and mental health issues. And the first one that they talked about isn't even a trauma, really. It's more of a grief response, and it's shattered dreams. My loved one's never going to be who I thought they were going to grow up to be. Our marriage, our relationship is never going to be the way I dreamed that it would be. And so it's important to talk to families about not just their kind of symptoms of things, but their experience of a life that was unimaginable to them. And so it's important to kind of understand that there's a lot of grief involved in this process. The others all make perfect sense. Dangerous, out of control behaviors, yelling, threatening, legal involvement, emergency rooms, life-threatening medical conditions, crisis calls, overdoses, potential overdoses, suicide attempts. I was working with a family recently, and their son had taken the car and was going over to a friend's house, and he didn't come back. And as the night went on, the dad went down to see if the car was in there somehow, and the car was there, and the son, who was in his late 20s, was in the car, in essence, deceased. And they Narcaned him, and he survived. But how many of you, you've all heard stories of similar situations. And so to think that a family is going to come to you for care, or family members are going to come to you for care and not be traumatized and not have that need for hypervigilance and control, and to not necessarily want to buy what we're trying to sell, is really an important process. And a skill. It's not always, this is like, I just finished teaching a class at the University of Colorado, Denver, in their marriage and family therapy program. I taught it the last 4 semesters, and that it was called Family Issues, Addiction, and Trauma. And in essence, I taught the whole semester the model that I'm kind of telling you about in 2 hours. So, and it's amazing how open the students were to that information, but how different it was from what they get in most marriage and family therapy programs. The second is the issue of post-traumatic stress disorder, that while not all family members meet the diagnostic criteria for PTSD, when you ask them about symptoms that they have and how they respond, they will tell you the same things that people who have post-traumatic stress disorder will tell you. There's anxiety, there's fear, there's anger, intrusive thoughts, nightmares, flashbacks, hypervigilance, the need for control, sleep disturbance, feeling detached, etc. So in a research project, it was actually the same research project that I was talking about a minute ago, I asked families, and I still ask this question, it's part of our assessment tools that we use when families first come into our program. If you've received a telephone call from a friend or a family member, extended family member, who knows that you've been through the ringer with your loved one and their addiction and their mental health issues, and their loved one has just been diagnosed with something similar, and they say to you, can you give me some insight into what our lives are going to look like? And I had 40 hours of back in those days, tape, recorded responses. And when I coded them, if you look at the slide, you'll see that there were very common emotional responses that they talked about, very common cognitive responses, common physical responses, common behavioral responses, and then their defenses. And one day I had this slide up on a projector. I had it projected on a screen. I was going to do a lecture for the clients at the Foundry, and a client walked in and he looked at it and he said, "Is that for us?" And I said, tell me about that question. What are you seeing on there that would tell you maybe it's for you? And he said, I have all of these. And so that idea of there is a parallel process, and I'm not going to, I think I might talk about it. I don't remember if I put the slide in or not, but the idea that there's a parallel process that families are going through in the earliest phases of treatment that are identical to what the clients are going through. And the idea of powerlessness and what do I have control over? What do I not have control over? Is it a disease or is it a weakness? There's so many things that we take for granted, that we just sort of start in. But this idea of assessing, what would you tell someone if they asked you what life has been like? And I've shown this slide to 1,000 families, and I've never had a family ever say, boy, I don't relate to any of that. Most families say, I relate to most of that. And so Kimberly just wrote, yeah, we end up taking on their addiction. And that idea of families want to talk about their loved one's addiction. They want to be convinced, and they want to understand, and they don't necessarily like talking about themselves. They don't want to be the client. But I think we have to be able to, I'll show you how we do it. And it might work for some reason. Okay, so this is research that we did in the family program at Foundry. We basically asked all the family members that came in at the time. It was 292 family members to do a questionnaire on symptoms, and these are symptoms of a lot of them. Most of them are trauma-related symptoms, but also burnout-related symptoms. And if you look at those, feeling tired and a lack of energy, 48.8% sometimes, 42% often. Feeling nervous, 50% sometimes, 43% often. Feeling scared or frightened, 48% sometimes, 24% often. Worrying, 27% sometimes, 70% often. Thoughts you can't push out of your mind, intrusive thoughts, 55% sometimes, 30% often. Feeling tense and wound up, 53% sometimes, 35% often. Sleep disturbances, 49% sometimes, 30% often. And so this is what families are coming into us with, that are symptoms that they're experiencing on a pretty regular basis based on those numbers. And so to understand why they may struggle with us focusing on them when it just stresses them out even more. And so it is important for us and for anyone who works with the families in our practices to understand that they're not coming in with as blank a slate as they believe, and that we have to recognize that if we're going to be helpful to them, we have to really be able to meet them where they are. And that's why that idea of calling someone who doesn't want to change unmotivated, and I think that's, to be quite honest, ridiculous. They are highly motivated, but they're highly motivated to be as safe as they can be. Okay. So these all of these slides pertain to the idea that individuals who have loved ones with addiction tend to meet the criteria for post-traumatic stress disorder. The second is that it creates a long-standing pattern of fight or flight. And so in my research, I found that the impact on safety and autonomic nervous system dysregulation from trauma of someone that we love is really at the root of things like hypervigilance, control, enabling, overprotection, defensiveness. And so I always say that telling a family member to stop enabling is like Nancy Reagan telling an addict to just say no. It's shaming and it's absurd. And the idea, if you ask anyone who and I don't like the term enabling, we use the term codependency. And if you haven't read Rob Weiss's book, he kind of looks at the difference between codependency and prodependency. And a lot of people disagree with me on this, and I'm okay with that. But the idea of, if you look at the definition of secondary trauma, the symptoms, the patterns, when it happens, how it happens, what we do to deal with it, we look at the symptoms of codependency, they're the same thing. And so I have stopped, and our program has stopped using the term codependency altogether. Because I think what we call things is important. And what we call things with families indicates a course of action or a course of therapy that should be followed. And I think codependency has been just changed and used by so many different places that it has taken on a really negative connotation about what they're doing and how they're doing it. And if we look at developmental trauma, it's not what happened to you, it's what didn't happen for you, or what's happening around you. And so when you ask someone who has gotten into trouble for giving their loved one money, that we would say, well, that's enabling. If you ask them, so I was doing a group, and I asked the group about enabling. Your loved one just walks in the front door of the house. It's the end of the month. They're going to ask for rent money. What happens? Well, they didn't want to talk about that. They wanted to say, well, if I don't give him money, he's going to be homeless. Or what if I don't give him the money and he's on the street? They wanted to talk about the loved one. And I said, no, I mean, we can answer all those questions, but I want you to tell me, yeah, that's so interesting. I've been told to detach. How do you do that? And the idea is we tell families that they need to do less, not more, and really different, rather than just doing the same things over and over again. And so if we think about burnout, the impulse is to do more and more and more, not less and less and less. So when we tell a family, look, you need to do less for your loved one and let them, even though that's the right thing in the big picture, that may be speaking Greek to them. That may just not make any sense to them. And so what families said to me when I said the front door opens, the loved one walks in, the family member said, I immediately catch my breath, because I know they're going to ask me for money. I know we're going to have conflict. And my heart starts to race, and I start feeling tight in my shoulders and in my neck. And I try to say no, but then they push back. And then eventually I get afraid that I don't want to have a problem. And then I just give them the money. If we look at the symptoms of trauma, aren't all of those symptoms of sympathetic nervous system dysregulation? Increased heart rate, tightening of the muscular structure, a rolling over of the shoulders for protection, acquiescence, all of those things. So I'm of the opinion that we have to really begin to look at enabling in a different way. And same way with hypervigilance, same way with control. Okay. The second thing that, and this all ties to this idea of autonomic nervous system dysregulation, or the constant state of fight or flight. There was a book that was written in the 1980s called Shattered Assumptions. It was written by a cognitive psychologist at the University of Massachusetts at Amherst. And she said that based on the water we all swim in, and based on societal norms and expectations, that even though the world is dangerous in certain places, that we are somehow convinced that the world is safe and relatively benevolent, that people are generally pretty nice. And the second is that the world is meaningful, which is important. What that means is that it's not random. It means if I do the right things, and if I'm responsible, then I can control my environment. I can control my world. This third one is good things generally happen to good people. And so she said, when a trauma happens, the world is not a safe and benevolent place, that it's a really dangerous place. And that the world isn't meaningful, that I was just walking down the street. I was at an ATM machine, and this guy robbed me. That even being the most responsible person on earth does not make me immune or invincible from traumatic events. And then good things, I'm a good person, and bad things have happened to me. So in that, family members get to us at a point where they can no longer assume that they have control over the negative outcomes that will reap benefits because they're good people. And but they keep trying, because that's the only alternative they have. And so depression, intrusive thoughts, a breakdown in interpersonal trust, anger, rage, feelings of vulnerability, all of those things become what families experience in a dangerous world. Again, people are highly motivated to stay as safe as possible. And so they try harder to control their world. So family members pressure family treatment to sort of meet their safety needs. And so that idea of asking, well, how's my loved one doing? And what can you tell me about what's going on with that? And then they get frustrated if you can't tell them, because over the course of time, the loss of this belief in safety, the safety of the world, and the assumption of having some control over things, that they become disillusioned. They have a loss of self-worth, a loss of self-confidence, and so they actually put it on you to actually make them feel better. The other thing that I find that they do, and this is from my research in intensive care, pediatric intensive care units back after our son got hit, this is my dissertation, was that what family members will do is they will ask every member that they run into of the treatment team the same set of questions, in the hope that if someone, that it'll all be pretty consistent, everyone's on the same page, that probably means that things are pretty good. But if one team member says something that is different than the others, they will often begin to question, people are just trying to make me feel better. People are telling me good things because they don't want me to worry, which just causes them to worry even more. And so this is hopefully explains some of why family members can be so difficult when a loved one is in treatment. I had a dad who came up to me when his son was admitted, and he said, I just need to tell you that my son's a liar. And I said, well, lying's part of the illness. And he says, no, you don't understand. My son is a liar. He will lie to your face. He will look you in the eye and he will lie to you. I said, well, okay. He said, I need you to assure me that you're going to inform the treatment team to not believe what he says. I said, I will do it. And so a week after that, I get a phone call from the father, and he is furious with me. And I said, whoa, what, why, why are you so upset? And he said, my son hasn't seen a therapist since he's been there. My son hasn't seen a physician since he's been there. The groups that you said were going on, they don't go on. None of those happen. I said, how would you know that? You're not here. And it dawned on me that his son had just gotten off of phone restriction. And his son probably called him that morning and just told him did exactly what the father told me he would do. Lied to him about everything. And when I said to the dad, how would you know? You haven't been here. And he said, my son, and then he stopped and he realized what he was about to say. And I said, yeah, your son, the liar, told you. I said, can we stop talking about your son and start talking about you and how much this has impacted you? And how do we help you get to a point where you can begin to deal with your son in a different way? Because if you can't, it's going to have its negative impact. This is a map of the autonomic nervous system. Peter Levine of somatic experiencing, and Eric Waltersdorf, who was one of his protege in the early days, have developed this as an easy way to help families, or to help their clients, understand how trauma impacts the sympathetic nervous system and how the parasympathetic nervous system works. And I show this to show you this star. And then what we've come to understand is that families who live in a constant state of fight or flight, they're not in a relaxed state, which is calm and responsive, awake, full executive function, prefrontal cortex online, the ability to remember things and problem solve, or even slightly anxious, or stressed, slightly anxious, maybe a little nervous, a little tension, but Walterstorff would say the relaxed state is like being in Maui, and the stress state is like being in New York City, just a different level of activation of the nervous system. But these families are coming to us in a constant state of being up here. Highly anxious, angry, panic symptoms, intense physical tensions, powerful fight or flight response. The prefrontal cortex is going offline or is offline. So that the only kind of coping and memory that they have to rely on is old long-term memory. And so we would expect more arguments. We would expect a more difficult time for family members to integrate the new material that we're introducing. And that over the course of time, as the clients call this the marble map. And we have this in every one of our group rooms and in every therapist's office, so that we can begin to help clients. We think trauma integrated work is helping clients begin to understand, as I'm getting frustrated and as I'm getting angry, to be able to imagine and picture the nervous system activating the way it does. And so I just show you that to say, the family's not coming to you here. They're coming to you here. And there are implications for how you talk to them, how you treat them, how they respond to you if they're in that constant state. And again, different families are going to be in different places, but just that idea of picturing, who am I talking to? What kind of a brain am I talking to right now? And to be able to kind of help them begin to understand, it's really important for them to move that down here when they're talking to their loved ones, so that they can problem solve, and so they can not get so angry or so anxious when there's disagreement. The third thing that I found in my dissertation is that perception is far more important to the family than reality. And so one of my favorite quotes by Shaw and Halliday is, the crisis is not the problem. It's the family's constraining beliefs that restrict alternative views about the crisis that become the problem. And this is an old model called the ABCX model. It was developed in 42, 49, something like that, by Reuben Hill. And he basically says that when families experience, this is a model of family stress. When there is a stressor, it doesn't matter what it is, that the family will always be trying to balance their understanding of the problem with the resources that they have available to them to solve the problem. And so as therapists and as coaches, we are often trained to be focused on resources. And so we're going to refer them to, how many of you have made referrals that people don't follow through with? And the reason they do that or don't do that is because what you're recommending does not match their perception of the problem and how they understand it. Their water that they grew up in, and their own developmental trauma, their own transgenerational trauma, their own parents' addiction. And so this idea of, and this is a different color red, because from our perspective, our family perspective, this is the major thing we're working on with our families in the initial 4 weeks or so. And that idea of really helping them to understand things differently. So family member perceptions, experience of stress and anxiety associated with the traumatizing event will influence interactional patterns, coping mechanisms, and the degree of emotional consequence experienced by the family system. And so we rarely get families in this first phase. They will continue to try the same things that they've tried before. And in family therapy, we say more of the same always results in more of the same. So in family stress theory, if they have a problem and their perception of the problem will dictate to them what resources they're willing to use, whether it's going to therapy, whether it's reading a book or doing anything that they think is the right thing, will dictate the solutions that they identify to solve the problem. If it doesn't work, and if in their best efforts, the problem continues, in family stress theory, we say that's a crisis. So crisis isn't about magnitude. Crisis is about how solvable is the problem. So we would call this the double ABCX model that says, this is the family we get, not this. Sometimes we get this family. And we did a research project at when I was at Florida State, where we found that families at the earliest phase would prefer a more hierarchical interaction with their family therapist or whatever. The idea of they tend to be more open to hearing suggestions early on. They don't see themselves as the experts in the problem. When they get to this other side, this other phase, so this is pre-crisis and post-crisis, and so more time has passed. Now there are several more pile-up stressors: financial stressors, relationship stressors, legal stressors, medical stressors, all of these things that are now exhausting these resources that they used to have. So this family has a lot more resources than this family because so many have been exhausted. This perception is now either really hardwired or they're ready to make some kinds of significant changes. So this is really, when we talk about creating a new normal, it's about helping them begin to alter their perception of what the problem is, where it comes from, potential areas for change and growth. But boy, this perception piece is really important, and why people don't do what we ask them to do. And then the last is, from this section, is systemic trauma. And the idea that the longer a family stays in a trauma response, the more family members who have trauma from the addiction, the more it's going to interact with the way family members interact with each other. And this is where we'll really begin to see these significant shifts in family organization, rules, roles, rituals, routines, relationships. This is the cause of increased conflict, anger, resentment, emotional distancing, emotional intensity, shifts in intimacy. And this is where boundaries begin to close off, and internal boundaries get really diffuse. So there's enmeshment and those kinds of things. If the external boundaries are really rigid and closed because the family needs to kind of circle the wagons, it prevents any new information or help from coming in, but it also prevents other family members from getting help from outside of the system. So the system becomes a kind of anxiety producing or anxiety maintaining system. And so that when they get to us, while they may say that I always think about how many times I've said, I'd like all the siblings to come to the family program, and how often the parents will say, they've been through so much. I don't think that they need to be here to do this. Well, we're going to talk about in the next phase, the family disease model, how critical siblings are to family healing. So I hope that makes sense. So we have burnout, and we have disillusionment, and we have exhaustion, and we have anger and cynicism, and mixed with secondary trauma, which is post-traumatic stress disorder symptoms, changes in the organization of the family, fight-flight system, changes in perceptions and understandings, and now changes in the way the family interacts with each other. And so the way I kind of look at it is, if this is the family, these are all the things that they're dealing with on a daily basis: intoxication, anxiety, agitation, intrusive thoughts, dissociation, frustration of other family members with each other, financial, this family is constantly being barraged by symptoms on a daily basis. So it's important to understand that each of these people will have very different stories of what's happening. And so let's say this person is the individual with addiction, and this is a sibling, and the person with addiction gets into an argument with the father. This person's not in the middle of the argument, but they're watching it, they're witnessing it. They're as concerned about the father's well-being as they are with the their siblings' well-being. And so each of these people are going to have a different kind of view, a different perspective of what's going on. And that will influence how they show up for treatment. It'll influence their attitude about the addiction, about the person, and their beliefs about why am I here? Why do I need to be here? And that's why when we get to the therapy, I'll talk about questions that I like to ask to bring that to that. I want that to happen pretty fast, that discussion. Okay, so understanding substance use as a chronic disease. And so this is a quote from a publication that I did on secondary trauma, and basically says illness can be conceptualized as a narrative or story about the subjective, the experience that each family member has, and the interactional behaviors associated with the illness or disease within the family system. It's not the illness that people are responding to. They're responding to how everyone in the family is dealing with the symptoms and dealing with the illness. The family's perception or worldview associated with the illness will dictate the interactional patterns associated with it. And again, it is about perspective and perception and helping people begin to understand that. And chronic disease management supports that idea. So this is that parallel process that I was talking about, the impact of history, transgenerational transmission, perceptions and beliefs about the illness, what caused it, what maintains it. Is it a disease, a weakness, moral failure? Is it okay to ask for help? In my family growing up, where there was addiction and there was family, the one lesson that I learned in that family was, what were you thinking telling anyone what was going on in their house? Why would you say that? Why would you tell this person this thing? And so this idea of, am I allowed to talk about this? What are other people going to think? Acceptance, accepting the diagnosis, accepting that it's a disease, accepting that everyone in the family will need to work on it. Connections, that they really do need social support, not just the loved one who has addiction going to meetings, but everyone having their own sense of that. Medical support, dealing with wellness, illness. So I don't see what the family is going through and what the client is going through as different at all. I think that, there's certainly differences, but it's the same thing. Powerlessness, control, hypervigilance, trust, ANS, dysregulation. Family members go through this just like clients go through this. And so that's why I call our program trauma integrated and family and family inclusive addiction treatment. And I'm not going to talk much about our program, but so this is what John Rowland basically says, that all chronic illnesses have three phases. A crisis phase, which is what happens from the time that the illness begins to the time that it's diagnosed, and how the treatment plan is implemented. If it's successfully implemented, the person has a pretty high likelihood of managing that illness well. If it's not, then they have a pretty dubious or painful process of lapsing and periodic use throughout the long haul phase. And then the last one is termination, the kind of mourning and loss issues from think of diseases like Huntington's disease and multiple sclerosis and other chronic diseases. But I look at schizophrenia and mental health disorders as chronic diseases in the same way as I would look at this. And so some of the things that Rowland says needs to happen in this first phase is like family understanding themselves as a system, psychosocial understanding of the illness, beginning to really recognize that it's an illness, but it has social implications and it has family implications. Family appreciation of individual developmental needs, that just because this person has this illness, we're going to have to limit maybe some activities for everyone in the family until we can get all of our energy into helping this loved one begin to manage their illness better. Now that needs to shift in the chronic phase when the person has the illness under control, or that's the right word, but is managing their illness. We have to make sure that those siblings now get to go through the life cycle stages of developing autonomy and learning freedom and learning how to be in friendships and relationships while still being involved in their family of origin. So you can look through those, creating meaning and mastery and competence of what this means. Organization, managing the shift in the 5 R's, and compassion fatigue. So our family program is focused on those tasks. And once that person has moved into a recovery process, then we have a second phase that begins to look at the developmental tasks of mastering autonomy for all family members, balancing connectedness and separateness, minimizing relational skews and dealing with conflicts in the family, those kinds of things. So this is the foundation of Roland's model. And what he says is, if you're working with a family that has a chronic disease, there are 5 general areas that you have to understand. And the first is a general assessment of, or 3-generation assessment. How much, let's add the trauma piece while we're at it. The idea of, does this family have a history of addiction? Does this family have a history of mental health issues? Does this family have other struggles? And so really beginning to help families begin to understand, how did these 3 generations impact the family's view of help seeking and health and illness? And how does that influence the rules and roles and routines, rather than asking for help because we grew up in a family where asking for help was seen as a weakness? We're going to alter our family organization, and so that we don't have to ask for help, but we can manage it by ourselves. How do these changes either allow people or not allow people to move through healthy developmental life cycle stages? And you think about childhood into school, into middle school, into high school, into the launching stages of life. Each individual has different kind of life cycle tasks that they need to meet. And so, and sometimes it's about leaving the family and becoming comfortable in the world. And sometimes it's about coming back to the family and being able to be comfortable in both worlds. And so this falls apart in most families, particularly where there is a child with addiction, and that everything begins to focus on the one with the addiction, and the other family members, the other kids, don't get those life cycle stages met. When we throw trauma into this mix, we can begin to look at how that impacts everything from a 3-generational assessment. And that 3-generation assessment is really important in that we look at how successful were these prior generations in managing this addiction? What were the messages that they sent to us as kids about our grandfather's alcoholism? And he'd show up at our house drunk, waking everybody in the house up, when he would knock the Christmas tree over every Christmas, those kinds of things. Begins to develop this kind of belief system, these schemas about, are we okay? Are we not okay? Is it okay to have secrets? Is it okay to, there's a book written a long time ago called I'm Okay, You're Okay. And I always thought that it should have been called I'm Not Okay, You're Not Okay, but that's okay. And the idea that, the healthiest families are families that really allow people to struggle. And so this is that. So now take one last look at this, is the 3-generation assessment is the foundation for understanding each of the following aspects. Health and illness belief schemas, we assess those because it either supports or inhibits help-seeking and family perceptions of illness and problems. When families talk about, I want to get back to normal, they're generally talking about this, to where this continues to work. The organizational issues, the 5 R's, the rules, roles, rituals, routines, and relationships, will either promote change and growth, emotionality, or it will keep families stuck in the same idea of don't talk, don't feel, and don't trust. And the life cycle stages really influence long-term relationships, resentments, and individual development. And the idea that if I didn't get to do the things that I was supposed to learn how to do, I'm going to probably resent my brother or sister who has an addiction issue, or I'm going to resent my parents for not taking better care of me in that process. So these are all things that we assess in our family program as we're going forward. So let's take the last we have less than a half hour, so I'm going to get into this. So the mission statement for our family program is to help families shift from we're a family that supports a loved one in substance abuse recovery to we're a family in recovery from substance abuse and trauma. And the idea of we want to remove the identified patient role from the family and add that we're all just people in recovery. We're here to help each other, support each other, but do our own work. And so it's interesting that clients will often get mad at their families for participating in the program. And they'll say, you don't need, it creates a little shame for them. The idea that you don't need to go to that. Like it's on me. I'm going to get better and you're not going to have to worry about it. And so often families will say things like, no, I'm participating because I want to support you. Well, what does that imply? I'm in a one-up position. I'm not really doing this because I have been impacted. I'm doing this because of my responsibility to take care of you. That in fact reinforces the identified patient role. If the family member says, look, I am learning so much about myself in this process and realizing how impacted I've been, not only by your addiction, but by other things in my life, that, we're a family that's going to get our act together. And we're going to work through this. And how different that's heard by the client from, yeah, I'm here to support you. Well, he should be grateful that I'm here to support him. Well, that's not really how that works. Okay, so now into the therapy pieces. Do all family members need to attend? That's a common question. The answer is no. So if you think about this mobile, if one of these things, whatever they are, were to begin to make some fairly significant shifts. So this is the person with addiction, and they have been getting progressively worse. And as they've been getting progressively worse, they've gotten more distant from the rest of the family, which required this family to begin to make systemic changes in order to maintain the system. If I can get one other family member, let's say this one, whatever role that person plays, to begin a process of insight and change, it's going to force the rest of the system to have to shift to rebalance. So, other family members may be supportive, curious, annoyed, or defensive by the changes that this person is making. But make no mistake, they will notice the changes and respond in some way. And so it's up to the one person participating to practice the new skills and decide that regardless of how people respond, I'm getting better. And when that happens, it forces the system into a state of disequilibrium, which promotes the opportunity for change. So I don't believe the whole system has to be in there. I think we have to have one person who is heroic and willing to really make these remarkable changes. So this is out of my book. It says, as far as the new normal is concerned, like any other area of your life that you desire to change, learning more about it is the prerequisite for action. New insights stimulate new solutions. New solutions allow for new actions. New actions allow for different relationships, and different relationships promote family healing. And so that idea of when families ask me, what do you think we should do? The reality is that most people do more of the same, and they just do it harder. In family therapy, we talk about first order change versus second order change. And first order change is, I'm going to do the same basic things that I've always done. I'm just going to do them harder, stronger, louder, more consistently, but more of the same always results in more of the same. So second order change is when we establish new insights. And that's going to give us new solutions that we would have never even dreamed of as being possible until we understood the problem differently. So I'm tying together my research in this, and I'm tying together that kind of chronic disease management, and the idea of, if we can help them to understand that the problem isn't the story that they've told themselves, that it's a different story. And that opens up the idea of, well, if it's a different story, then maybe there's some different solutions. And if there are different solutions, then maybe we can begin to heal by treating each other differently and by acting differently. And so that's just sort of a setup to that. So the importance of starting with family beliefs. This goes back to that, what do you think we should do? How should we do it? The fact that people don't do it, and the idea of motivation. So I've already kind of talked about that slide. So in working with families with addiction and trauma, there are 3 areas that I think, and this is the work of Don Catherall, who's, again, he's at Northwestern also. And it says, when families fail to process and mourn the losses associated with trauma and substance abuse, to mourn the losses, which means these things happened, we haven't adjusted to them, and we've created the solution that has now become the problem. It leads to 3 areas of dysfunction. The first one is the family's connection. A breakdown in the family's ability to care for its members. Think about what Figley said about compassion fatigue and compassion stress, is the breakdown of families' willingness and ability to care for each other, and the impact of burnout. The second is family's reality, the development of distortions in the family's consensual reality, and how the story is different for each person, and they don't talk about it because it usually creates crisis. And then the last one is the family symptoms, the continuation of issues related to the trauma and related to the addiction. So as a family therapist working with families with addiction and trauma, these are the 3 areas that I work on in the therapeutic process. Now, I'm a big advocate of coaching. And I think in a perfect world, and this is how our family program has family coaches, and it has a family therapist. And at this point, we have 1 coach and 1 therapist, and they work hand in hand all the time. And so our coaches have certain tasks and certain things that they do, and they do it beautifully. And so it's education, coaching, and support. Educate families on substance abuse, post-traumatic stress disorder, developmental and secondary systemic trauma, the impact of history on perception. What do the 5 R's mean? Life cycle stages. They get through all the material that we've just talked about. And I have videos for all of the things that we've just talked about that they can watch, understand, work with the coach to recognize how it fits with them. Number 2, help families recognize unhelpful perceptions about the problem. And the idea of being really curious about, let's talk about that view that you just expressed. Tell me more about that. And being able to unpack that. Teach skills for regulating the autonomic nervous system. Critical. And to do it by, like, we have the map, I have a video that teaches families how to manage their marbles, as they call it, but to understand the map and to understand the importance of regulating. So they get that, and then our coach, her name's Jana, begins to work with them on, so how would you use that? What do you do with that? We teach resourcing skills. We have a person that does EFT training for the families, the tapping, to help them regulate. Number 4, self-care, setting boundaries, going to sleep, nutrition, exercise, medical care, taking care of themselves is things that coaches can begin the process of helping with them. Trying to convince them on whatever level is necessary of the need for both professional and social support. And so often, I had a mom whose son had relapsed, and I said, "Has he gone to any meetings?" She said, "Well, he says it doesn't work, so he doesn't go." And I said, "Have you been going to any meetings?" And she said, "It doesn't." And then she stopped, and I said, "It doesn't work. That's why you don't go, right?" She's much nicer than I just said that, by the way. And that idea of they think it's important for their loved ones to go, but they don't necessarily see the need themselves. And so the idea of this first phase of clinical work with them, of coaching, is to help begin to make sense of issues like understanding and perception of what the problem is and how we begin to address it. Communication skills, teaching them how to have good active listening, avoiding blame, sort of polyvagal, the ventral vagus nerve, and how that impacts what we can hear, the impact of nonverbal communication. And then the last is self-reflection, learning limits, practicing mindfulness, etc. And so from a coaching perspective, all of those things are really very possible. And we have it set up that we have a group every Wednesday night where we talk about these specific things. From a therapy perspective, we're really trying to help families restructure, rebuild, restore and repair family relationships. That's what we're trying to do. And we have a series of questions that I'll talk about in a second. But we want to help them begin to recognize, how have the rules changed? And how have the roles changed? And what's part of your new normal or newer normal that you want to create? Discuss troubling past experiences. Nothing more powerful than a father coming in to a session and saying, I've kept a secret from everyone. Your mom knows, but I was sexually abused as a kid. Or I had this trauma and had this near fatal accident. Or getting someone in this family to begin to say, we've all had something. And we're going to support each other through all of this. Respectful and affectionate. I'm trying to get to one set of slides because I know I'm running out of time. The Therapeutic Alliance, I always say you never give a traumatized client a reason to act like a traumatized client. If show up on time, do what you say you're going to do, follow up on what you said you were going to follow up. If I'm highly motivated to stay safe, I'm going to be looking at you for consistency. I once wrote in an article that people, this is convoluted, so hang in there, people who have lived consistent lives of inconsistency consistently focus on the inconsistencies of others. And the idea that they're watching your every move to see, can you be consistent? Are you safe enough to listen to? If you make a mistake, do you apologize or do you acknowledge that? Are you creating a safe clinical space? So generational assessment we want to do, managing the autonomic system in real time. And so in real time basically means if I see an argument starting to happen, I will often ask the family to hold on a second. Do you want to have this argument or not? And the idea of sometimes arguments are really beneficial, but what's going on? And so we have them look at the marble map and begin to talk about, when he was talking, this is what I was thinking. And this is how I started to feel. And this is what I felt in my body. And this was my impulse. And so helping people begin to put together where my marble is on that map often is coinciding with what's going on in my body and what's going on in my emotional state. And so I think that the benefit in the therapy setting where you're talking about difficult things is that you can address autonomic nervous system dysregulation in real time and really begin to teach people to talk about. You just heard how your wife was addressing what you had just said. What are your thoughts about her description of that? Or were you aware that that was the case? And it opens the dialogue for a whole new thing. Telling the story and creating a healing story. Healing story is a model where we ask clients to answer 4 questions. What happened? Why did it happen? Why did it happen to us? And what will we do in the future if anything similar were to happen? And we have each member of the family, given the fact that they all have their own story, to answer those 4 questions. And then we have them come together and read their answers to those in the family group and then begin to have a conversation. So it's very cool. Dr. Figley created it. I'm certainly not going to take credit for it. And then I think, yeah, this is another poster that's was always in my office, that when they start to get ready to argue, I have them go through this and see where their marbles are and begin to teach that process. I miscalculated some of my earlier discussion. Okay, so these are the questions that I want to assess, and I'm going to end on this. For most families, I want to assess what's the problem that brings them to therapy. Do they all agree what it is? And in many cases, they don't. How do they deal with the agreement or disagreement? And so I think that's a valuable discussion is, you know, are you all on the same page? Who has the problem? Is the identified client the only one with the problem? Are they open to being a family with a problem? The third, how do they understand the problem happening to them and their family? So often people say, well, this doesn't, when our son got hit by a car, the very first thought I had, and I remember it when I was told, I remember thinking, this doesn't happen to families like ours. This is what you see in the news. So that idea of how do they understand this happen? We're good parents. How does this happen? So why is it happening? Why now? Why not 2 years ago? Why not 2 years in the future? Have there been periods when the problem went away? Families usually want to minimize exceptions. This is basic solution-focused therapy. But that idea of what were you all doing differently during that 2-year period when your dad didn't have a drink or didn't use drugs? Why does it happen to the identified client and not to other family members? Why is he the addict and not the sister? What might be a trauma happen? Might be a trauma that happened to mom and that she, it impacted the way she parented, or it happened to dad and it impacted the way he parented. What's the family's understanding of substance abuse, of trauma? And I'm just giving you these as like food for thought. What have they done to try to fix it? In hindsight, how does the problem impact each family member? Okay, so those are the questions that I like to ask. But these are the questions that I think are important when you have a highly conflicted family that are coming in and they're angry and they don't particularly like being asked to be there. That these are the questions that I will always ask. I'll ask them, what's it like to be asked to attend this meeting? And so often, if there's resentments, it's like, you know, it's just Jane being Jane. You know, she's been doing this to our family for, 10 years, that she gets into crisis. We all have to go to see a therapist. And that beginning to look at, well, let's talk about that. And how do other people see it? And so, and it's almost like in the old days of strategic therapy, prescribing the problem, and where people are angry. You know they're angry, so you give them an opportunity to start by talking about that. Number 2, what will have to happen before all of you as a family become willing to see yourselves as necessary pieces of this puzzle? And the idea that the family can't heal if you're withholding, or if you're refusing to change, or if you don't think you need to change. What does that do to the mobile that as it's trying to adjust to a newer family normal? The next, how does anxiety, distrust, resentment, fear, or anger need to be resolved, or how much? I had a dad, I asked the family this question, and the dad said, I don't think we have any resentments at all. I think we're pretty open. And his oldest son looked at him and said, what are you talking about? We are the poster children for resentment. We resent people for resenting us. And so that idea of to give the family the opportunity to begin a discussion about no, we have this. We need to do this. And oftentimes it's the person least expected to be the voice of reason is the voice of reason. How have you been impacted by substance abuse, trauma, and other symptoms in your life? Have you had trauma? You know, and then the last one is, how does the experience influence how each family member has coped with the substance abuse and trauma in the family? So I know that's an awful lot of stuff. Oh, this is the program that we have, and I'm going to do this in 1 minute. And just to show you how we have built our program, that there are 5 weeks. Addiction is a chronic disease, Trauma 101, impact of addiction and trauma on family functioning. Week 4, keys to family healing, creating a newer normal. And then week 5, communication 101. And in that process, we have 2 groups a week. We have an individual session with the families. And so we're in the process of working with Arizona State University to take our model and build an app that treatment centers who are kind of trying to decide what to do with their family program can utilize all of this material in an app process. So I'm going to these are the references. These are all the articles. You have the slides. You can go to this last few. I know time is over. This is my contact information. The Denver address is actually my old business address. I live in Tampa now. But my phone number is 720-515-6724. My email address, the website for my website are all there. Thank you so much for the participation. You guys are awesome. It is so good to be back in Florida. I'd love to meet all of you at some point along the way.
Thank you, Dr. Barnes.
I think that's it.
Thank you, Dr. Barnes, for your presentation.
You're welcome.
We have included Dr. Barnes's contact information so that you may contact him with any further questions. Please note that we're going to go through a few items of business before we conclude. Please see in the chat the panel for today's survey. Additionally, when the webinar ends, your web browser will populate a message that says the host or presenter would like WebEx meetings to open a website on your computer. Click continue to be automatically redirected to the evaluation. You must sign in to your account to complete the evaluation. If you do not have an account, you can register at no cost. You may do so by clicking haven't registered yet. You must use the same email address you used when you registered for today's webinar when you set up your profile in FATA's system. This is the only way to connect your attendance and your profile. For CEs to be reported to the CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. If you need to add or update your license number, you may do so by logging in and clicking Edit on the Professional Information section of your profile. You will get a third opportunity to complete the evaluation through a follow-up email later today. The evaluation will close at the end of the day on Wednesday, May 29th, 2024. For assistance with account login, account registration, or evaluation completion, please fill out a Contact Us form on our website. Please note that we do not email statements of credit. Rather, after we verify attendance and the completion of your evaluation, a statement of credit will be posted to the professional development section of your profile in your FATA account within 30 business days. You must have attended the entire webinar and completed the evaluation for a statement of completion. We are not permitted to provide partial credit. As a reminder, the recordings and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org to navigate to the Resource Center and then click on Training Library as shown on the screen. Thank you all for your participation in today's webinar. Thank you again to our presenter, Dr. Barnes, for his insightful information. We would also like to recognize the Florida Department of Children and Families for funding today's education. Have a great day, and we are going to end the webinar so that the evaluation will pop up.